Welcome to today's broadcast of North Idaho College Public Forum. The crew is comprised of NIC television students, and your moderator is North Idaho College political scientist Tony Stewart.
Today we wish to discuss with you, ladies and gentlemen, a very serious topic, the question of AIDS, and we're going to particularly emphasize the rising problem of this disease in North Idaho, and also the formation of a support group to deal with individuals who have been tested HIV positive. We have a very professional person as our guest today that I've worked with before on programs dealing with the field of healthcare. Our guest is Jan Palmer, who is from the Panhandle Health District, which includes the 5 northern counties of Idaho. Her position at the Panhandle Health District is nurse epidemiology. Jan, we've worked with you before, and thank you for coming back. You're so always willing to be with us, and we appreciate that very much.
Thanks, Tony. It's nice to be here.
Also, I'm very happy to welcome back, once again, as always, regular panelist Steve Schenck, who is the Dean of College Relations and Development at North Idaho College, and I shall ask Steve to commence the questioning.
Thank you, Tony. Jan, I wonder if we could start by having you tell us a little bit more about what it is you do for Panhandle Health District.
At the Panhandle Health District, I am responsible for epidemiology. Primarily, I spend most of my time doing sexually transmitted disease clinic and surveillance and control of STDs, HIV infection, and then spend some time in communicable disease like measles, rubella, other types of vaccine preventable, and other diseases like that.
Maybe we can define some terms, because I always have to stop and think STD is
sexually transmitted disease.
And if you tell us what epidemiology means in layman's terms.
It's really the study of people, and primarily in my job it's the study of disease among people. And that's what I do, is responsible for the control and surveillance of communicable disease.
Thank you. Now if we could move to the topic. AIDS is something we've read about, has gotten a great deal of attention and publicity in recent years, maybe more some time ago than it's actually receiving now. Mm-hmm. There was a big surge of attention for a while, and it's less in the spotlight than it once was. Could you spend a few minutes and give us sort of a status report on the AIDS epidemic nationally and regionally?
You bet. Right now we're looking at about 130,000 cases within the United States. New York City claims about 1/4 of those within their city limits. So they have a tremendous impact by this disease. In North Idaho, we have seen 17 cases now of full-blown AIDS. Idaho itself has only seen 65, so a goodly number of those have been in our community. And we're seeing this disease among every type of individual that has been identified as having risky behavior. Homosexual men, bisexual men, IV drug users, hemophiliacs, people that have received transfusions, and sex partners of those people. So we have literally seen the whole gamut of people at risk for this disease.
And it might be helpful to talk just a minute about the disease, and I'm sure we'll get into the whole question of transmission or communicability mm-hmm. later, but what is it? Is it always fatal? How does it manifest itself in a victim? Okay.
The disease, or the syndrome itself, AIDS stands for Acquired Immune Deficiency Syndrome, is caused by an infection with a virus called HIV, or Human Immunodeficiency Virus. The virus is transmitted either sexually or by blood contact, and it manifests itself with a very long incubation period of anywhere between 2 and 10 years. Maybe in another 10 years it may be 2 and 20 years. We don't really know fully what that incubation period is going to be. The incubation period appears to be dose-related as well, whether you have a little bit of virus infected or a whole lot of virus infected, as to how long it takes you to get sick. Many of these patients present with symptoms somewhere after 2 years, and the symptoms are swollen lymph nodes, weight loss, diarrhea, fevers, kind of vague flu-like symptoms. Swollen lymph nodes are very common, and they may stay with that type of symptomatology for several years before they actually get sick. And the patient then finally presents, usually in the emergency room, with either pneumocystis carinii pneumonia, which is a rare form of parasitic pneumonia that we see in AIDS patients primarily, or some other type of opportunistic infection that literally takes the opportunity to infect them because their immune systems are being destroyed. AIDS is not actually a disease but a syndrome, and a syndrome associated with the destruction of the immune system. After that immune system is beaten down, then they are infected with many different kinds of diseases, many of them fatal.
Thank you.
Jan, when I invited you on the program, one of the reasons not only to discuss this overall problem, but to talk about what is happening in Idaho, because recently you've made some statements about the growth, and you've already indicated on the program that there have been 17 cases here in North Idaho identified, and I assume that's the 5 counties of the
Right.
Panhandle District. You indicated there's 67 across the state of Idaho. I guess my first question has to do with, for all the cases that have now been identified, as you indicated that there may be a rather significantly delayed period depending on the amount of exposure to the virus. Do you have any educated guess as to how many cases that may not yet be identified?
I wish I knew the answer to that. We know of at least close to 250 people in the state of Idaho that are testing positive with HIV virus antibody. And among those, we know that those people will probably eventually become ill with the syndrome. As far as those that have not been tested or those that have been tested in Washington anonymously, I don't really know what those numbers are, but far more than I'm aware of, I'm sure.
Another thing we should make clear with our audience, I think, is that when you indicated that, use the figure 250 that have tested positive, explain to our viewers the difference between testing positive and actually having the full-blown disease.
Right. What we've discovered with this disease is exposure, either by sexual contact or blood exposure. The person becomes infected. About 6 weeks to 3 months in most individuals, they will test positive for antibody within their blood to that virus. That test literally just tells us that they have been exposed and not that they have actually become infected, although the trend is showing that you show positive on that test and you will eventually develop the disease.
In relation to that, from some national studies that have been done, or national television programs, particularly with sex partners when both have been exposed,
Right.
isn't it somewhat a mystery that in some cases that one partner will develop the symptoms and the disease and the other partner will not? In the research, is there any explanation? Is it like other problems in the medical field that some people are more susceptible than others to
I think
viruses?
it truly does have some relation to susceptibility. The same story of the salmonella at the family picnic, 4th of July picnic. Not everybody gets sick, even though everybody has been exposed. And I think that happens with HIV infection as well.
While we're on this issue of Idaho and the very significant growing problem that you have notified us all about, or really set out an alarm that this is a serious problem in Idaho as well as other places, although there is statistically a higher rate, I guess, in San Francisco, New York,
Sure.
and other places. I would like for you to take a little time to talk about how you are dealing with this, not only with the question of treatment and all, but I believe a support group has been formed, and would you go into the reasons why that is and how that is progressing, and how individuals could contact the support groups?
Sure. Just to give you a little bit of history, in 1986 we had our first case of AIDS diagnosed in Coeur d'Alene. And at that time we became aware of the fact that at some point we would need more support than just myself at the health department for these patients and their private physicians and families. And slowly through the next couple of years we saw one patient at a time, basically. And the need for a support group was beginning to develop, but not really as much as was suddenly starting November of last year. We were seeing trends of larger numbers, 2 or 3 a month being reported. And all of a sudden we had patients that truly needed support. And we had a gentleman come from Boise who was HIV positive and had been part of a support group there. He came to visit me and said, we need a support group. He basically said, I need a support group here. And I said, we need a support group here. And he's been instrumental in helping us develop that support group. And we met 2 weeks ago, and we had 4 persons involved in some way with HIV infection show up at that support group. We now had 8 show up last night. So we're seeing an increase in interest, and the group is wonderful in its energy and its help for the people that are involved.
Steve Sheen.
While we're on the topic of support groups, maybe we should talk a little bit about the progression of the disease and why it is so important to form that kind of a group for AIDS patients.
I think, in all terminal type illnesses, there's a lot of grief issues and a lot of trauma associated with terminal illness. In particular with the AIDS syndrome, what we're seeing are very young people that are sick and clearly not developed enough to have that platform for their grief issues, and so it's very much traumatic for them. Added to that, the risk, which is directly related to ignorance, of losing their jobs, their homes, their families, their friends, and their churches, and suddenly being alone and terminally ill. And support groups are just essential. Many of these patients go through the course of their illness with very little touch. And one thing that we do in our support groups is make sure we give everybody a hug. So at least there is some degree of touch for them, and they can come merely for that purpose, if not to be helped as well, and to help others.
Well, if we're going to educate people a little bit in this program, maybe this is a real important topic to focus on. And it's got to be a concern. We've seen it in some of the publicized national cases. The young man who died recently after a long AIDS illness, who was banned from schools,
right.
and just had a very difficult time in some communities, in some settings. To what extent does a person need to be worried if a friend or a relative is an AIDS victim? To what extent do they have to be worried about contact with that person?
Right. And we've been dealing with that some in our support group as well. The issue of being spread only by sexual transmission and by blood exposure. Casual contact is not a means of spreading this virus. And they've done partner studies, they have done household studies. They did a study in Belgium where there was a home for orphans, and half of these kids were hemophiliacs, and there was no transmission within that school. And the small children sucking on the same toys, and really literally a lot of body fluid contact and still no transmission. And so in all those studies they've shown that literally there is no transmission without sex or blood exposure.
Now, sexual contact is pretty easy for most of us to define, but what do you mean by blood exposure?
Literally, blood exposure can come from a razor blade that you used to shave, a toothbrush, or by someone bleeding on you, gum bleeding, right, exactly. Or sexual exposure, once again, there can be blood exposure as well.
I see.
Jan, while we were dealing with this particular aspect, I had some other questions, but I'll follow through on Steve's questions. One of the purposes of this program, of course, and it has been for many years, is to be educational in nature. In fact, we're a PBS program, and one of the services that I think that North Idaho College provides is to try to provide information, and I think it's a very, very valuable tool that we have via television. Would you please take a little time to educate our audience to preventive methods? We hear such issues as safe sex, so forth, and anything that you could provide the audience, I think would be most helpful in how to try to prevent the contracting of their own exposure.
I spend a lot of time in high school classrooms talking about prevention of your own exposure to high school students, because they are considered to be the next potentially high-risk group for catching HIV infection. And what I talk to them about is abstinence and the prevention of HIV transmission by literally avoiding sexual contact. And I go in to explain the difference between abstinence and celibacy, and the fact that abstinence does not mean you don't have significant relationships. Abstinence means that you do not have oral, vaginal, or anal intercourse. And the kids seem to be more receptive to that, just to say no and don't ever have it, and that means you don't have sexual thoughts and you don't have hormones, and I give them permission to have those things, just to know their own limitations. I also talk about safer sex techniques, the use of condoms. Condoms with non-oxynol 9, which is a spermicide, can be either added to the condom or can be laced into the condom by the way you purchase them. And they can be a good preventative measure of HIV infection and most sexually transmitted infections as well. And then I go on to talk about monogamous relationships and how it's a great concept, but in many adolescents it's a very unsafe practice. And one partner can be not monogamous and put the other person very much at risk for sexually transmitted disease and HIV infection. And that's what the message I would like to give to the public too, is that those are the choices that you can make. This is not an easy disease to get, and you really have to make an effort and make some poor decisions in order to get it. We also talk about IV drug use, and certainly I can't stand up in front of a classroom of high school students and tell them not to use them if they're using them, but I can tell them not to share needles, and if they're not using, not to start, and if they are using, to try and get some help, so they can prevent not only death by the drugs, but death by HIV infection as well.
That's very important to send that message to all the population, and you're doing so. I want to go back, talk a little bit about the problems that AIDS victims may suffer, and I think that probably what was revolutionary in this change was the courage of Ryan White, the young man who Steve referred to that died recently. And Ryan received this disease not by any actions that he had taken himself, but he taught a lot about courage and about fear. And I'd like to give you the opportunity to talk with our viewers about throughout history, when we've had fear of different diseases, and this is not the first time, oftentimes isn't it true that someone comes along to teach all society, in this case a very young person, that we must recognize a disease or a problem, and at the same time we must be very rational how we deal with that, and we must be sensitized to those individuals and families that face these challenges.
Exactly. Ryan White, at I believe age 13, was diagnosed in 1984 with HIV infection and AIDS, and at that time was excluded from school. He went as far as the Supreme Court to receive the right to attend school and to give other children the right to attend school as well. Ryan died April 8th, I believe, of this month, and it was a very long course. I think he was only given 6 months when he was diagnosed, and so he had a long course and a lot of time spent doing a lot of education and giving a lot of energy towards the education of AIDS. And we have had a similar situation in Idaho as to a child who had HIV infection, and they attempted to exclude him from school. And with the help of health departments and a woman I believe came from back east to help educate the school, they handled it beautifully, and the child did attend school until a few months before he died. And the whole community handled it very well, and that was down southern Idaho.
In your work here, where you have to deal with this on a daily basis, the message that Ryan White taught, has it made life different for you in your work here? Is it created a somewhat different attitude?
Ryan White helped me out some, but I think the patients that I deal with on a personal basis day to day have helped tremendously. Mm-hmm. You know, they're wonderful people, and they're suffering from a terrible disease.
Yes, thank you. Steve Sheen.
Jan, we know that that AIDS is in North Idaho. That's a problem we're going to have to deal with for some time to come. Mm-hmm. You've talked a little bit about what's being done to educate young people who are a high-risk group. What about the medical community? Are we well prepared in this region to do what can be done, understanding that there's no cure for AIDS, but to do what can be done for patients?
We are prepared to see HIV positive and AIDS patients in our hospitals, and our physicians, I'm hoping, are educated and certainly will seek education as they are sought to treat their infections as they're faced with them. We've had a few patients that have come in through the emergency room with acute illnesses. They've been handled well. You know, there have been episodes that have been had to dealt with by the hospital, things that haven't worked out as well as they should have, but things have gone real well. Many of our patients, though, are still seeking their medical attention in Spokane, and I hope to see that change quickly, as I think the patients that live in our community have a right to receive their medical care in the community that they live in, and not to present in one hospital where they don't have a physician present. And I think that we need to work towards that here in North Idaho.
What impact has AIDS had on health care in general? We've talked a little bit about Ryan White, and as I recall, he transmitted AIDS from a blood transfusion. Mm-hmm. He was a hemophiliac. So apparently there has been some change in the way blood is handled in medical care facilities across the country. Are there any other impacts of the AIDS virus, of the disease, on medical treatment?
Well, certainly we're seeing tremendous costs to medical care for patients that are HIV infected and have full-blown AIDS. Their exposures in hospitals can be very lengthy, can be very costly, including respirators and ICU and those kind of costly medical care. Many of these patients are Medicaid patients. They are, only reimbursable by a certain portion of what the doctor's costs truly are. They can be refused by physicians because physicians have the right to refuse Medicaid patients because they're not fully reimbursed. And so we are seeing some problems in patients receiving medical care. And in addition, we're looking at tremendous costs to these patients that fall between the cracks of Medicaid and private insurance and literally don't have a means of paying for their medical care.
In dealing with this issue of treatment too, I'm one of the founding members of Hospice of North Idaho, and hospices across the country, as you know, Jan, are a wonderful service, and they've grown in Idaho. I think there's something like 26 hospices in Idaho. I'm no longer on the board, but just before I left the board, I was cognizant of the fact that in addition to the number of cancer patients we've had, that we have also had some AIDS patients with hospice. And as a board member, our director just briefed us that treatment and care for the AIDS patients was significantly different than, say, cancer patients. Mm-hmm. Could you take us a little bit more into an explanation to help those people that are in our community that might face this? Not only that there are organizations like hospice available, but what are some of the cures that they need if they can stay home instead of being hospitalized at certain points in that?
Exactly, and I think that's truly what AIDS and HIV positive patients care to be, is at home and out of the hospital environment. And hospice and other home health agencies have been real helpful in providing that care. What we see in AIDS patients is that they fluctuate between being well and being sick. And they're on literally a nasty roller coaster ride where they may be, acutely ill and in a terminal phase, and the next week they've come back and they are functional again and going to go home again, and back and forth with tube feedings and with hyperalimentation and other kinds of IV services that certainly need to be provided in the home. And as much as the medical care is traumatic for them, so are the grief issues. Because at one point you're in denial, the next point you're in acceptance, and then you're well again and you go back into denial. And it's very, very difficult for these patients to get some grasp on their grief issues.
Are there, in addition to the support groups, are there some people that are in the field of religion or in medicine that are becoming almost part of the support, that is, that they are specializing in a way of support? Because I hear you saying that the AIDS patients need a lot of support that they are not getting that other patients get. The rejection, that's an extra burden.
Judgment that occurs.
The judgment that occurs. But are you finding in our community particularly that there's some people coming forth to be helpful in a very special way, for example, from the religious community?
I hope so. I haven't seen it.
You haven't?
We hope to put together a coalition for helping persons with AIDS, with HIV infection. And when that coalition comes together, I hope to see the religious community and other persons in the community that are interested to come out and help. And this coalition literally coming out to help those people that are infected, make their lives easier for the course of time that they have.
Steve Schenck.
Jan, I know research is not what you do, or at least I don't think it is, but maybe you could take just a second and talk to us about the future of the disease. It shows no signs of abating in terms of the spread, although education is one tool in the fight against it. Can you hold out any hope at all for those people who have tested HIV positive at this point in time? Is enough being done in research? Is there a cure on the horizon?
There's been a lot happening over the last year, and what we've seen now is that we're using a medication called AZT, now not to prolong sick people's lives, but to prolong healthier people's lives, those that are infected that have no symptoms, or those that are infected have a few symptoms but are still well and able to maintain a job. And we're using that medication in lower doses, which are less toxic. And we don't know what the ultimate result will be, but my guess is that we will prolong some real quality of life for a goodly period of time. In addition to that, we're using pentamidine, which is an aerosolized medicine we use by respiratory therapy that prevents the #1 killer of AIDS patients, and that's pneumocystis carinii pneumonia. We're using that in patients that are susceptible at a certain T-cell count in all the laboratory work that we do, so that they can be eligible for that medicine. We're also looking at 2 vaccines that have been created now, Jonas Salk being the creator of one of these vaccines, also the creator of the polio vaccine. And the testing of these vaccines now in the United States, and using volunteers for testing, including the Catholic clergy have been invited to participate in using over 65-year-old priests and nuns who would not be susceptible to HIV other than conversion through the vaccine, and using them in the studies as well. And those things, I think, are real high points. And when we look at 21-year-old men who are infected with HIV virus, and you hear people within the community say, why treat them? They're going to die anyway. Well, why not treat them and see if they can't survive long enough for something to help them? And that's kind of the goal that I have.
What about this area? We've talked about some of the things that are being done. Are there some real needs? Are there some things that we aren't doing well here that we should start doing better?
I think the support group has been a tremendous asset to us, that we have been able to come up with that type of support care for patients. We need to work towards buddy system arrangements where HIV positive and AIDS patients have daily visitors from people that are just coming there to hold their hand, bring them their groceries, help them out a little bit. We need to look at potentially housing for them as we see that many more patients will not be eligible for Medicaid. You know, I think right now as it stands, you can get Social Security, then you wait 2 years before you're on Medicaid. You may or may not get medical benefits during that time. The state of Idaho is not set up for AIDS patients, young men with AIDS infection and terminal infections. And we may need housing at some point, a shanty project like there is in San Francisco. And there's a lot of things that we're going to look at the horizon that we need to begin to work towards.
Are you comfortable with what's being done educationally to try to teach people how not to become infected?
I do a lot of education, and clearly right now that is the only means of prevention, is to educate. And not only is it a means of prevention, but it's a means of reducing the prejudice against these patients and to stop the judgment of what they've done in the past that makes them guilty of their infection, more so that they are human beings that are infected with a virus, and letting the public deal with them that way.
We don't have much time left, but would you like to take just a moment to make a recommendation to those public policy makers in our state that they should address this issue?
Yeah, all I can say is these patients clearly need more assistance than they're getting. And Idaho, unlike Washington, California, Florida, where other people are getting much better services than they are, they deserve better than what they can have here. And we need to address that. We need to change that in Idaho for them as we see more and more patients.
Jen, I want to thank you for being on our program. As I've said before and at the introduction of this program, you're always available and you're so helpful in serving the health of our community, and we're very grateful to you.
Thanks.
And Steve, thank you for your questions. Ladies and gentlemen, our guest has been Jan Palmer, who is with the Panhandle Health District, and she's been discussing the very, very important issue of AIDS and what is happening in North Idaho and around the country. We would like to invite you to be with us again next week at this same time. Until then, please have a good week. I am Tony Stewart.
North Idaho College Public Forum can be seen at the same time each week over this station. This production was videotaped earlier by an NIC student crew for viewing at this more appropriate time.